Greetings. My name is Dr. Daniel Reeders. I've been a cardiologist for about 4 decades, and I have a dramatic title here, Dead Silence, the hidden plaque killing your patients before they know it. Um, so what it is that most medical professionals tend to look at statins. If your cholesterol's high, they order statins. But there's a huge gap because that only takes care of 20 to 25% of the risk, and not directly answering the other 75, 80% of the risks, which we can call lives, is not addressed. And they typically assume primary care is going to take care of it or the patient themselves. And there's often a lack of guidance, in my personal opinion. So this is a huge gap in care because this presentation is a summary of several presentations I have on my YouTube, and I actually have a document that you can request that summarizes this. So, of all of these presentations. So let's go ahead. I'm going to do this in storytelling in a way because that's a lot more interesting to me, and I can give a better presentation. So, and then you have this slides you can look at. So this gets to the old story, thousands of years old, in many cultures where the king, who is loved by his kingdom for the most part, was found one evening underneath a lamppost right in front of the palace gate. And he was on his hands and knees looking for the keys to the kingdom, to the palace to get into. Interesting. And the people came up and said, "Hey, king, what are you doing there? On your hands and knees?" He says, "Well, I'm looking for the keys of the palace," kind of like a doctor for their patients. And then the people said, "Well, where was the last time you saw the keys?" And he said, "Well, over there in the darkness." So that's the story. And this talk is about moving the lamppost where the information is to get exact precision based upon science, where to look to treat patients. As you know, heart disease, such as heart attacks, sudden death, strokes, which are the brain, are the number one killers in modern countries like America. And so this is a topic everybody needs to know about. And so let's move the light where the lamppost where it needs to be. That's a fun story. So in cardiology, they think of it as residual risk. We put someone on statins and get them to low levels, like for secondary prevention, down to an LDL calculated, not measure, of 30, and we're missing 75, 80% of the rest of the risk, and people think the work is done. So this is upside down thinking, and then that's why this is a passion topic for me. So everybody thinks that you get from over the decades of living in a modern society, you get no plaque going to endothelial dysfunction, the lining of the blood vessels that makes them vulnerable for atherogenic particles like cholesterol crystals to enter inside the wall, sneak in. The smaller the particles, the more they can move in. And then eventually they grow and become necrotic, which are dangerous, vulnerable plaques. They can rupture, which can cause a heart attack or death, or a stroke. And then the plan is to put them on statins, which turned it into calcified hardened plaque, and that's the best way to go. And that's very gross, and there's, in my opinion, better ways to deal with that. Let's keep the arteries healthy. Let's get the soft plaques smaller, regress. Let's get the necrotic plaques to turn to unnecrotic vulnerable plaques that are soft, and then so that we don't develop hard plaque and we get rid of the dangerous vulnerable art plaques, these lesions inside artery vessel walls that feed the heart and the brain, and just go the other way instead of the one-way street, if possible. And it's been proven scientifically. We know this. My mentor in medical school, Dr. David Blankenhorn at USC, worked with Caltech and JPL and developed technology and showed that they can actually reverse the plaque inside of arteries walls that obstruct blood flow and can rupture and cause dangerous catastrophes. So if you don't have a tight lesion, these vulnerable plaques can be in vessels that are silent. They don't obstruct blood flow, and then all of a sudden they rupture open, a catastrophe occurs where blood clot forms inside the plaque and outside the plaque into the vessel wall, occludes blood flow, and when no blood flow goes to the brain or the heart, you have a catastrophe, and it's often sudden. And so a patient may end up in an interventional suite, in a cath lab, getting CPR, dead, getting stents and bypass surgery. And that's often heralded by no symptom at all or very little warning. So let's target the vulnerable plaque. That's the 911, that's the emergency. And we can figure that out by different measures or metrics, we call them biomarkers, that include imaging and blood tests. Patients' symptoms are usually silent until they're not, as I've stated. This is typically a silent process. Even when people end up getting stents and bypass, they do better when we treat the underlying problem inside the vessel wall. So let's look at the biology of the vessel wall, and we look for different issues such as this necrotic core, which is filled with debris. Let's get it out of there. The cap that covers the plaque, let's, if it gets too thin, less than 65 microns, it's likely to rupture. More likely, that's dangerous. So we want to get that thicker. We want to get rid of the inflammation in the vessel wall. We want to make that cap thicker. We want to get the debris in the white cells and everything going on inside the vessels. We want that to shrink. So we can target that. So you can review the slide, but I just reviewed it. And then the strong signals are a couple. So LDL calculated that is universal. In a cheap test, there's a cheap test also called ApoB, and instead of measuring the weight of the particle, it actually measures all of the so-called all of the particles that cause plaque. And those are called atherogenic particles. So you get a particle number that's much more accurate than just getting a weight, the number of particles. And the smaller the particles, the easier they can, so to say, sneak in through the vessel wall into the wall and start building a bigger plaque inside. And that test is called ApoB. It's available everywhere. It's cheap and you can get it back pretty quickly. And this is a much better marker. There are other markers that are really good, like something called an HSCRP and a lipoprotein A, which is a genetic factor, which we'll talk about in a little bit. So we want less particles, less ApoB numbers, and larger particles, and we know how to do that. Whereas LDL-C that you're typically measured misses most of this. That's why this marker is a better marker. And this is my target when I treat patients. One of my targets that when you show it goes down, you know you're helping the patient. It's a metric of treatment and of danger. So major adverse cardiovascular events, MACE, let's not forget major cerebral vascular events, adverse. So they have similar pathophysiologies. And these are some of the metrics we can measure that are very potent. And all of these have more predictive values and are better treatment markers than just getting an LDL calculated, not even measured. And some of these are very cheap and you can get them back very quickly. The lipoprotein A we talked about is a very bad marker. One reference says it's 6 times worse than the LDL cholesterol. Um, but when you measure LDL cholesterol, you measure also lipoprotein A is included in that measurement. And you wouldn't know unless you measured. Same thing with ApoB. So there's some nuanced understanding. We want to know if the LDL that's in there is damaged also, that's worse. And we want to know if the particles are small or large. When you have an elevated troponin, that's a kind of a 911, and that's where we go to the emergency room, cath lab, and get possible procedures done. It's also a measure of heart failure. CRP doesn't measure inflammation in the vessel wall, it measures how much inflammation is in your body. So this is an independent risk factor, but not so targeted to vessel wall. So, but it is helpful and it changes day to day. A more chronic long-term marker of systemic inflammation is something called GLYC capital A that's readily available. The lipoprotein A, in my opinion, while you're checking cholesterol, you need to at least check this once in someone's life, and it does change throughout a life. For instance, menopausal women, this all of a sudden goes up. So the female hormones were lowering this. And then this is a very good marker, LPPLA2, which measures inflammation inside of arteries. So this is more specific compared to HSCRP. And then there's some other really great markers that don't come back right away. One is called MPO, myeloperoxidase. It shows neutrophil activation in oxidative bursts. Remember the word oxidative. That's an important marker, and it's red flag. If that's elevated, the patient's in danger. The same thing with MMP9, that some national labs you can get it, some you can't. And that actually shows also an unstable plaque, a vulnerable plaque. We want these to be in normal range. These are red, red, red flags. Oxidized LDL, damaged LDL. This is what causes part of the problem, the damaged LDL. Fibrinogen, the ability to clot. And there's some that are not on here that are mentioned later in the lecture, TMAO and omega-3 levels and some others that we'll mention soon. So we want to know what the soft plaque markers are and what the necrotic plaque markers are. And here they are. And you can break them down. So if you have, for instance, worried about lipid oxidation, you can look at those and you know then to target your treatment there. If you worried about the matrix and about danger, danger, then these would be the ones we would explore more and we would like to normalize. If you want to know about inflammation, here's some of them. These are all in medical guidelines. This is not fringe medicine. This is precision medicine. Somehow I don't like the name precision medicine because it misses something. it's not quite accurate, so I haven't found a better word. And then metabolic factors, these are there. So as you treat metabolic factors, often the small particles that sneak in get larger and they can't sneak in so readily. So these are all measurable. Now let's look at a calcium score. Everybody comes in with, oh, I have a calcium score. Let me treat the calcium score. That just measures hard plaque pretty much and misses the soft plaque. And so getting a CTA, which also includes a calcium score and is covered by insurance more so than the calcium score, and then you can get an AI overread. There's different companies. One is Clearly, but there's a bunch more. And it depends on what insurance coverage gives which company. And these are rapidly evolving technologies and rapidly um, being assessed by insurance companies because the patients can it's plausible they can have better outcomes. And it's also easy to do clinical studies to show plaque regression, elimination of necrotic plaque, soft plaque. And so we're going to get a lot of data from real life information without invading a patient. So this is a lot's going to be coming up. So when a patient comes and they say, what's my risk? You can get, if there's a significant risk, a CTA with AI overread of the coronaries, and then you can find out exactly how much soft plaque, hard plaque, necrotic plaque there is, and the severity of the blockages. And it gives complementary information to cardiac catheterization angiogram, but it also gives more information where the cath gives a little more information on other things. So they're complementary tests. They give similar different information. So in one of my first YouTubes that we talked about a 71-year-old male who's asymptomatic, had a family history of heart disease, a family history of elevated LDL, ApoB, and lipoprotein A, and who had an omega-3 index of around 5.6. Which is at the bottom level of normal for the US labs, but we know that the goal should be over 9, and the hemoglobin A1C was going up, and so was the waistline, which is dangerous. So the CTA showed a three-vessel disease with extensive soft plaque, some hard plaque, and some necrotic plaque, not that much. And so there were three vessels involved, and one of them was a critical blockage. And so, yeah, just 1 second. Here I am.
Okay, here.
Yeah, come on in.
Hi, quick question.
Yeah.
I don't know if you know about this patient that was for velocity in room 121. It looks like he was under CCU service, but they just downgraded him.
Who?
Velocity is his name.
Yeah, I know Velocity.
So he just went to SVT again. He's been there for like 8-ish minutes, maybe almost 10. Blood pressure's okay. The fellow, they don't know really what to do with him.
How about some adenosine or
It's okay.
private massage?
I think they did the private massage. Okay, but we were saying adenosine, they're kind of staring. We
Where,
called
where are you? 121?
121.
I can rub on there.
Okay.
Some people said I have magical fingers.
Go, yes.
So that patient ended up getting a cath. The treating team never measured in the hospital the ApoB or the CRP because they said, we don't know what to do with those, even though it was an academic center and the patient went and got it in outside labs. And then we had more precision treating the patient. Their MMP9 was elevated slightly, so more aggressive care. So the good thing about the drug companies is that they can take a hypothesis like, let's lower the interleukin 1 beta and put them on a drug and see if it has an effect. And so they did that study with colchicine and with another drug called canakinumab or whatever you say it. And they've used other things and they've done studies and showed that if you treat these markers, that all of a sudden the patient does better. And so we can extrapolate to diet, moving the body, supplements, foods, and get the same results theoretically. And here's the different interventions, and they do different things. And for instance, to get an elevated hsCRP, which is not specific for artery, but is an important marker, for instance, um, it requires inflammation by something called toll-like receptors, PAMPs and DAMPs, that go through a system, and the NF-kappa B will go up, which is another marker, and the IL-1B1 and the TNF alpha. And then all of a sudden they tell the body to create interleukin 6, which can be measured, which tells the liver to make hsCRP. So we can pick this apart even more when we want to figure out what's going on with the patient. And different drugs do different things. So if there's a serious coronary problem or cerebrovascular problem, I tend to highly recommend drugs first and then prove that the other maneuvers are helping. We know they help, but often these situations are urgent or emergent, and we don't want our patient to die, have a stroke, or end up in the cath lab or bypass if we can avoid that. The DAMPs and PAMPs I mentioned, the danger signals, the NLRP3 inflammasome, the interleukin 1 beta release, the IL-6 production, then the CRP, and going to plaque destabilization. This is just one mechanism. I think we need to spend more time on plaque physiology. Also, that this is ignored by just only checking an hsCRP. And hsCRPs are very helpful. They're available in the hospital. They can check these. And in an acute setting, so is ApoB. We can get these back quickly and draw the other labs, and they can be followed up in the future. As an outpatient, we want to know about oxidative stress, the forgotten gatekeeper, so to be, being dramatic. We can't forget about the glycocalyx, which is hair inside of the endothelium, which faces the protects the endothelium, which protects the vessel. And so we need to work on those, and I'm going to do my next YouTube on this. This is can get very nuanced, but just getting some basic lab work is really helpful. I'm endorsing that. And then prevention is a little bit a wrong word because plaque develops over decades. So you already have it. So you're preventing a heart attack or death or a stroke, but the disease is already there in the vessel and very advanced often. Mediterranean diet with low sugar and colorful diet and lots of fiber is, and omega-3s could be not eating bad, so-called bad fats and eating better fats, particularly omega-3s, moving your body, losing weight, getting your gut working properly. Would you believe that most artery damage occurs after you eat? One eats that the you can eat best food or not so great food, and you can if you have a damaged gut, these foreign invaders go into the bloodstream and damage vessels. And at least with eating better food, which gives life, you promote a healthy gut lining, healthy metabolism, and digestion, and healthier factors that promote health. Whereas if you eat damaged oils and lots of sugars, for instance, you're promoting gut dysfunction and inability to keep the toxins out of the bloodstreams, like something called lipopolysaccharides, which come from the wall of gram-negative bacilli, which are extremely toxic to the whole body and to blood vessels. You want to get people sleeping and you want to get the nervous system regulated and managing stress. These all matter. All of these, what you eat, how you move, how you love, how you sleep, how you manage stress in your relationships, how you regulate your nervous system are all important. I know it sounds scandalous to think that what you eat affects your health. Who could believe that? Or these other things, and there are so many studies that prove this, and it's in our guidelines. So we can figure out risks based upon our different uh, biomarkers we get. I advocate getting not only an ApoB but also an LDL-C because there's information between the two, and at least getting one lipoprotein A, LP little a, and then at least an HSCRP in just about everybody, and also a hemoglobin A1C. And then if we're worried, we can look at other things like an omega-3 level, um, and the gut with the TMAO. Homocysteine another thing that needs to be checked. That is independent risk factor for strokes and heart attacks that can be fixed with just eating the right vitamins. So we can, depending on what's going on in the plaque and the patient, we can determine what type of treatment we need to pull the lever on. So there's a war for statins and against statins. I'm not going to engage in that battle or all of the complexities. We're here just talking about science and precision cardiology. Putting the lamppost where the problem is and managing the patient with some executive functions, some data, information. And preventative cardiology is a misnomer because the disease is already there and often very advanced. So we want to figure out what we need to do. Now, if someone's having chest pain and elevated troponins, they need to go to the cath lab. If they're having chest pain, they may need a stress test. That's a symptomatic patient. The imaging is one of the most reliable biomarkers of all, but it's radiation and contrast exposure, so we can't do that every month. So we need to have some ideas. Also, there's things we can reverse, like we can treat sleep apnea, we can treat endothelial dysfunction, the homocysteine we mentioned, the gut health, the oral microbiome, toxic load like heavy metals, and your mouth bacteria can be found in people that die of heart attacks in the plaque. So can microplastics and other factors. Chronic kidney disease can be reversed. And how you think and feel affect your health in a big way. It can either promote healing molecules or promote unhealing molecules in your body that bathe every cell of the body. So this whole thing is there's a lot of noise in this healthcare space, in the hospital, in the clinics, when you talk to your friends and family on TV, there's so much noise. And what I'm talking about here is getting a higher signal and lowering the noise level so we can figure out really what's important and what we can really act upon. A beautiful, clear signal versus noise where you just can't be sure of what to do. There's so much noise. So I've already talked about this stuff, and it's here in the slides. Measure an ApoB, measure an LDL-C with the ApoB, get an HSCRP. Think about inflammation and gut health, and at the end of the day, and homocysteines and omega levels and what they eat, how you sleep, how you love, how your relationships are, how you move your body or don't move your body, and consider getting in an asymptomatic patient a coronary CT, or if you're in the hospital, sometimes this can be better sometimes than getting a stress test before going to the cath lab or managing the patient somehow. A lot of nuances. And then the residual risk that they all talk about is not residual, it's the bigger piece. It's metabolic, it's inflammation, it's thrombosis. Don't just settle on getting LDL-C levels to low levels for secondary prevention. You can cause harm there, that the harm is real. So we have to really understand what's going on and evaluate carefully. So this is a lifelong, over decades, silent until it's not. We don't want to know what happens when it's not because that's often a catastrophe. And when you have a catastrophe, you're behind the eight ball. So all of this is treat the biology, especially the vascular biology that's influenced by the whole body. Uh, Go to my YouTube channel for other deeper dives in the same topic, and I'm planning the next one to be on endothelial function, and then I'm going to get into other cardiology type things as the time goes on. I put time and effort into these, so they're not have much noise in it, and it's all pretty good signal. And if you go to these people that do the the scientists like Dr. Matthew Budoff, who started this calcium score, his talks would be a lot like my talks now. He's an advocate for CTAs of the coronaries. And so the medicine has moved forward, the expert world experts have moved forward, but it hasn't reached the bedside, particularly in cardiology, not yet.